Good evening, everybody. Thanks for joining us tonight for our webinar. I was going to do a little poll to see where you all work, but unfortunately the polls part of Teams has decided it's not going to work. So we'll get going because there's quite a lot to get through. So thanks for joining us. We're doing clinical implications of tube choice tonight. And what we'll do is I'll run through some introductions and housekeeping briefly first, and then we'll get started with the presentations. We've got some really good speakers joining us tonight, and hopefully the topic's going to create lots of discussion as well as some learning points to take away at the end. So I'll just introduce myself to start with. I'm Eleanor. I've been at ATOS since January as one of the tracheostomy clinical educators covering the north of the UK, and I work alongside some other clinical educators in both tracheostomy and laryngectomy, and we cover different areas of the UK doing study sessions, study days, virtual sessions and webinars like this. And my background's respiratory physio, initially in Cambridge, then moved to Lancashire about 6 years ago where I got most of my experience on respiratory high care. So I'm going to start with a talk about different features of tracheostomy and the importance of the technical data and dimensions, especially when considering how we pick the most appropriate tubes for our patients. And then we'll hand over to our clinicians who are going to help put that information into a more clinical context and provide a little bit more depth on some of those aspects as well. So these are our lovely clinicians that are joining us. Kate's going to be first up. So Kate is a clinical specialist physiotherapist in critical care and respiratory at Mid and South Essex. Sadly, Emily can't join us tonight, but I know she has worked with James on the planning of the content, so I still wanted to keep her in the intros just to get some credit for that. And Emily is an advanced practitioner speech and language therapist working in critical care and tracheostomy at New Cross. And then we've got James. James Barraclough is a consultant rhinologist, facial plastics and ENT surgeon, and the clinical director for the head and neck services. And he's also the lead for the tracheostomy and laryngectomy team at Royal Wolverhampton and Dudley Group. So this is just a bit of a brief overview, but I'll introduce our speakers in a bit more depth just prior to their individual talks. A little bit of housekeeping before we get started. All your microphones and cameras should remain off during the webinar, but if you do find that they are on at any point, if you could just pop them off so we've got all the focus on the presentations that are taking place. Just to remind you, the webinar is being recorded and you will have access to the recording after we've finished. You might find, depending on your view, that you have an option to navigate changing your own slides yourself through the talks. But to save people ending up on different slides to the presenter, we'd recommend just leaving that function and not touching it, just allowing the slides to change via the presenter. But if you do find yourself on a slide that doesn't look correct, you should have a button at the bottom of your slides that gives you the option to sync with presenter. So just click that and it should fix it. If you've got questions, can you please pop them in the Q&A function? And then we'll relay them to the appropriate person at the end of each talk. If you can't access the Q&A or you've got any issues, please post in the chat and one of my colleagues is lurking in the background and he'll probably transfer any questions from the chat to the Q&A just so they're all in one place and we don't lose track. We'll obviously try our hardest to answer any questions after each talk, but we do need to just try and keep to time because there's a lot to get through. So if any aren't answered, we'll just collate them in a Word document with answers and we'll send them out to you along with the CPD certificates and recording afterwards. So don't worry if you do ask a question and we don't get round to it, we will get answers to you. At the end, there is a QR code that will take you to a feedback form, and I'll also post the link to it in the chat. It will take about 3 minutes of your time, but we'd really appreciate you being able to complete it just so it helps us to continue to improve what we obviously provide and deliver in the future. And I just need to do a quick disclaimer from ATOS as well. So ATOS Medical provides a forum to facilitate discussions and questions. Nothing in our session provides any diagnosis, clinical advice, indication guide, warranty or guarantee. The discussion and answers provided are not specific guidelines or endorsements, and nothing in the webinar can substitute individual advice or guidance from a qualified healthcare professional. ATOS Medical doesn't suggest, imply or make any claims other than those detailed in the product manual. Now, that's all the formalities. So we will just get started on tracheostomy tube choice. So we're just going to look at understanding the importance of features, technical data and dimensions to support your tube selection decisions. And this is what we're going to hopefully cover in about the next 20 minutes or so. So we're just going to have a look at the overview of tube features and variations with a little bit of a recap of some of the main features. I won't go into great detail about all the main features because a lot will be familiar to a lot of you, and obviously I could probably talk for 2 hours just on that. And they will also be covered probably in a little bit more depth by some of our speakers afterwards as well. We're then just going to look at Traco Twist and Traco Twist Plus, including the important technical data, the dimensions, and why these details are really important when we apply them to clinical practice. And just to be clear at this point, so the information that I'm going to present in my talk is going to be specifically focused around the Traco tubes, especially Twist and Twist Plus, with those being our ATOS products and our area of expertise as clinical education team. So whilst the technical data is going to be specific to our tubes, many of the broader concepts around the tube features and the clinical implications can be applied to your trachea tubes in general. So hopefully if there's people that aren't familiar with the tubes or are using other tubes, there'll still be helpful learning points. And there probably will be other tubes and sort of examples covered by the clinicians after me as well anyway. So you should get quite a wide range of examples and perspectives throughout the evening. So we'll start with tube features and variables. So these terms should all look familiar to most people. These are most of the variations that you might see in clinical practice when using trachea tubes. Our main choices tend to be whether a tube is cuffed or uncuffed, single lumen or double lumen. If you work with adult patients, then the vast majority that you're going to see will be double lumen. Whether a tube has a subglottic port or not, and whether tubes are fenestrated or non-fenestrated. And the presence of your fenestrations is an option for both the outer cannula and the inner cannula on your tracheostomies, and we'll look at that and these features in a bit more detail in the next few slides as well. So this is a bit of an overview of those features and how they look on the tube. So this diagram is an illustration of the Traco Twist tube. So although many of those features are seen across your tubes, this is sort of specific to our tube, but you'll see them see the specific features across different tubes. They just might look slightly different. So if you look at the top right, we've got the neck flange, and that's where your tie is attached through your eyelets. And that flange also gives you a variety of information about your tube. So in this diagram, you can see a reference, which is 302. You might be able to see it. It might be quite small. And that corresponds to the type of tube, and also obviously makes ordering like-for-like tubes a bit more simple. Underneath that, you've got a tube size. So in this case is a size 8. And under that, we've got details about whether the outer cannula is fenestrated or non-fenestrated. So in this case, it's fenestrated. The Traco tubes, the colours correspond to whether the tubes have fenestrations or not. So if you want to identify the tube as fenestrated or non-fenestrated, the main detail you need to remember is that blue means fenestrated. So blue writing on your flange means that the outer cannula is fenestrated, and a blue 15mm connector on the Traco Twist or a blue locking ring on the Twist Plus means that the inner cannula is fenestrated. So then if you look down the right, you can see this. So you can see the blue 15mm connector on the fenestrated tube, and then underneath you've got an unfenestrated tube, which has got a white connector in this case. Underneath those inner tubes, you've got your pilot balloon and your pilot line, which is your method of establishing if your tube is cuffed or uncuffed from the outside. So the presence of that pilot balloon is only seen on your cuff tubes, and then your cuff is inflated and deflated via the little spring valve that you can see. And then when you look at the top left of that photo, you can then see where your cuff is, and that cuff is inflated on this photo. So a little look at your double lumen tracheostomy tubes. So your double lumen just means that you've got an inner cannula and an outer cannula, with the inner cannula being removable, so you can remove it, clean it, replace it. And these bring benefits, things like being able to clean the inner cannula, so then you reduce the risk of secretions building up and occluding the tube. It allows us a route to check the airway patency, as well as maintain the airway patency with removal of the inner cannula in the case of a blockage. And the diagram on the right here is one of the Traco Twist Plus tubes. So you can see the 15mm connector is not coloured, it's just like a clear one. But the locking ring is white for those non-fenestrated inner tubes, and that's the ring that's blue to identify a fenestrated inner tube for the Twist Plus. Cuffed tubes, so many people will be familiar with cuffed tubes. You can see from the image on the right, that's just the passage of airflow through a tube when the cuff is inflated, so straight through the tube. There we go, and then we've got the purpose of our cuff. So Purpose of our cuffs to prevent air leak between the tracheal wall and the outside of the tube. And therefore it prevents airflow from escaping to the upper airway. So it's important in your mechanically ventilated patients especially. The cuff will never fully prevent aspirated material reaching the lungs, but it can reduce and it will minimize the volume of aspirated material dropping down into the lungs. And then because of these aspects, your indications are your patients receiving positive pressure ventilation, those with poor secretion management, increased aspiration risk, and patients who are unable to ventilate adequately with a cuffless tube. And then obviously on the flip side, you've got your uncuffed tubes. So your uncuffed tubes tend to be used on your self-ventilating patients, those that can manage the secretions, so they don't require the presence of a cuff for that added airway and aspiration protection. Your patients with an uncuffed tube do ideally need to have an effective cough reflex or an effective method of chest clearance and secretion management to protect them from aspiration. And then we'll look at fenestrations, which is where I really wanted a poll to see what all of you use. So one of the features we can see are fenestrations, so whether a tube is fenestrated or unfenestrated. So your fenestrations are either single or multiple openings on the curvature of the tube. So it can be on the outer or the outer and the inner bends. So on the tracheo twist tubes, there's just fenestrations on the outer bend, and on the twist plus they're on the outer and the inner bend, and they permit airflow to the upper airway. So they're quite a big talking point for us as a team at the moment because their use can vary quite a lot between trusts. Some trusts won't use fenestrations at all because of the associated risks, and some trusts will still use them, but for varying reasons. So just have a think about what you tend to see in your trust and if there's a specific reason you do or don't use fenestrated tubes, because it's something that we might sort of have some discussions about in the future. So we've just got a little overview here of your potential risks and benefits of your fenestrated tubes. At the moment, there is a limited library of research in this area, but this is what we can currently draw from the research that is there. So in terms of benefits, the fenestrations do allow an increase in airflow to the upper airway, which can help phonation. It could reduce the work of breathing, but we don't have any values in terms of how much the flow rate is increased by the presence of fenestrations and how significant that actually is for outcomes. So it would make sense that that increased airflow might help improve tolerance to one-way valves or capping in patients who are struggling to tolerate those during weaning. But there are also disadvantages, and those include things like risk of granulation tissue accumulating, risk of tracheomalacia or stenosis, and the risk of subcutaneous emphysema, especially with your patients that are being ventilated at high pressures. There can be a risk of the air moving between the inner tube and the outer tube and then escaping through the fenestrations of the outer tube into the tissues. So these are the key recommendations that we found in the research at the moment. The recommendation is that your fenestrated tube should not typically be used as a first-line tube in new tracheostomy patients. Clinicians should consider downsizing and using unfenestrated tubes, or ensuring the patient has an optimally sized unfenestrated tube rather than looking at fenestrations. And we'll talk about this a little bit more in the next few slides when we talk about dimensions and what we actually mean by an optimally sized tube. And the last point is patients that do have fenestrated tubes just need to be optimally humidified to reduce the risk of secretions accumulating around those fenestrations and impacting their function. Now this bit. So we're going to have a look at the technical data and what this means in a clinical context. So this might be the bit people are less familiar with, or less familiar with how significant an influence it could have on outcomes. So if we're looking to choose an appropriate tracheostomy tube, we need to consider what we want to achieve with our patients or what our desired outcome is. For instance, you might want your patient, you might want to be able to provide effective ventilation, so be that mechanical ventilation or an adequate airway for somebody that's self-ventilating. We might want a tube that's going to provide us with the best potential for an effective wean and progression to decannulation. Or our outcome might be a bit of both of these. So you might want somebody that you can effectively ventilate whilst allowing commencement and progression of weaning. So establishing what you want to achieve is going to be the first critical step to actually choosing the most appropriate tube, and it should always be patient specific. It shouldn't just be a one size fits all. So if we think about the first outcome that we looked at there, which was effective ventilation. So to optimize ventilation, what we need is to optimize the flow of gas entering the lungs. So there's a couple of theoretical laws that help to explain the relationship between gas flow and other variables, which is really important in understanding the impact of that appropriate tube selection. So on the left, you've got 3 men, and this represents Ohm's law, which explains the relationship between gas flow, pressure, and resistance. So this law just explains that an increase in resistance causes a decrease in flow. But if resistance is increased, you'd then need to increase the pressure to actually maintain the same flow. So if you look at our 3 men, if the man in red increases the resistance, so if he pulls that rope tighter, there's obviously a smaller gap for the flow to get through. So the guy in green is going to need to work harder and increase the pressure to maintain the flow through there. The next law, which is one I can never pronounce, so do forgive me, is Hagen-Poiseuille's equation, which is based on the law of tubes. And that explains the impact of diameter on resistance. So in basic terms, a smaller airway diameter increases breathing resistance. So it means it's harder to breathe through a smaller airway diameter. So if you look at the 2 images of the straws and the pipes, it'd be harder for us all to breathe through the straws compared to those wide pipes on the right. And to achieve the same gas flow when breathing through the straws as opposed to the wide tubes, our breathing effort would have to increase. So the pressure would need to increase. So if you then apply this concept to your tracheostomies, a larger inner lumen will provide a lower breathing resistance and therefore increased gas flow or more optimal ventilation. Based on those laws that we've just mentioned there, we can work out these things. So we know that by decreasing the inner lumen from 8 millimeters to 7 millimeters, you reduce the air supply by 41% and you increase the breathing effort. Whereas if you increase the lumen by 1 millimeter, just from 8 to 9, it increases the air supply by 60% and it maintains the same breathing effort. So with that in mind, if our outcome was to optimize ventilation, then what we want to do is consider maximizing the inner lumen of our tracheostomy. So in many cases, that would be achieved by increasing the size of the tracheostomy that's placed, but not necessarily always, and that will become clearer in the next few slides. So think about the next one, so effective weaning and decannulation. So to wean or to decrease the dependency on the tube, we need to have space around the tube to allow that passage of air to the upper airway, as you can see in that image on the right. So the airflow to the upper airway then allows us to gain laryngeal resensitization, restore more normal breathing and cough mechanics, and allow the potential to voice through that airflow through the vocal cords. And if you think about the same theory as we used in the previous slide, the more space we have around the tube, the more airflow we're going to get to the upper airway. So if we think in simple terms, the smaller the dimensions of the tube, specifically in relation to the outer cannula size, because that's the sort of total size of the tracheostomy, the less space the tube's going to take up in the trachea. Therefore, there's going to be more space around the tube to allow that airflow to the upper airway. So it's then also important to consider the presence of your cuff as well. So you want your, the dimensions of your tube to take up the least amount of space in the airway as you can, but then think about what that cuff does. So even a fully deflated cuff is still going to occupy an additional space in the trachea compared to an uncuffed tube, and therefore have some impact on airflow to the upper airway. So if you've got a patient with a cuffed tube that actually doesn't require any periods of cuff inflation, and the wean is potentially not progressing as planned, then it's possible to consider things like whether changing to an uncuffed tube would be beneficial, because you might be able to get that additional airflow to the upper airway without necessarily changing anything else about the tube. So there we go. Looking at our intended outcome for effective wean and decannulation, we might want to consider downsizing tubes or the presence of a cuff, whether that's needed. And then we're going to have patients that don't fit into either of those categories, or they're a mixture of both categories. So you might want to be able to provide your optimal ventilation, but also commence and progress weaning. And this is where the importance of understanding your dimensions and tube differences can have a really significant impact on your tube choice and outcomes. So to optimize both your ventilation and your wean potential, you want the biggest inner lumen possible, so the biggest inner diameter of the inner cannula, whilst occupying the least amount of the trachea as possible, so the smallest outer diameter of the outer cannula. So you've maximized your inner lumen for ventilation, but you've minimized the amount of trachea it's taking up, so you've still got as much space around the tube as you can do to get that airflow through the upper airway. So to understand this, if we just have a look at the example at the bottom, you've got a Traco Twist and a Traco Twist Plus. Both tubes are a size 7. So in Traco tubes, the size corresponds to the inner diameter of the inner cannula. So that's the lumen the patient would be breathing or ventilated through when the cuff is inflated. That is their airway. This isn't the case in all competitor tubes. So if you are using others, then just double check those individual tubes and actually what the size corresponds to, because there are some differences. But I think there might be a little bit more about that in a future presentation as well. So if we look at these, both size 7 tubes have got a 7mm inner diameter of the inner cannula. However, the design of the Twist Plus means that the tube walls are thinner, so therefore the overall dimensions of the tube are smaller than its Twist counterpart. So you can see in the table, the Twist takes up 10.4mm of space in the trachea at the point just below the cuff, and 12mm just below the flange. And in comparison, the Twist Plus diameter below the cuff is only 9.8mm, and below the flange is only 10.1mm. So if you translated that to a bit of a case study context or a clinical context for a patient, so you've got a patient requiring a size 7 tube, placement of a size 7 Twist Plus would allow the same inner lumen for ventilation as the size 7 Twist would, but it occupies less of the trachea and therefore allows more space for airflow around the tube and potentially more ability to then commence weaning and progress weaning a bit better. So there you go, your tube considerations, if that's your outcome, is to think about your tube types and what you want your optimal dimensions to be, what you want to achieve. And as well as that tube choice impacting your clinical outcome, the awareness of these tube differences are actually really important for your emergency equipment provision as well. So when compiling our emergency boxes, we'd usually have the same size tube and we'd have one size smaller in the emergency box. Now your Traco Twist Plus size range goes from a size 7 to size 10. So there isn't a size 6 Twist Plus to be put in the emergency box as the smaller tube for somebody that's got a size 7 in. So your logical thinking, if you're not aware of differences between tubes, might be my patient's got a size 7 Twist Plus, so I'm going to put the same tube in their emergency box, and I'll put a size 6 Twist in their emergency box because there isn't a size 6 Twist Plus, and that must be smaller. However, if you look at the data we've got circled here, so if you look at the top right for the Twist Plus size 7, we've got the outer diameters of the tube, so how much of the trachea is being occupied by the tube. So one of these diameters is below the cuff, so that's 9.8mm, and one's below the flange, that's 10.1mm. If I get the next one up for you. So if you then look at the data here for the Twist, so this is for the Twist size 6 that you might assume is the smaller size. The outer diameter of the outer cannula below the flange is wider than that of the size 7 Twist Plus. It's 10.8mm. So if in an emergency you wanted a smaller tube size because you've not been able to successfully insert that same size, then the size 6 in this case probably isn't going to be any easier to insert. Therefore, the recommendation for a true smaller size tube for this emergency box would actually be a size 5 Twist. So this is why even within the same sort of make of tracheostomy, we need to be aware of these differences between tubes. And just to help us round all of that information up, just have a think about the potential consequences of not understanding tube differences or not being aware of them, or not being able to sort of underpin that tube selection with sound clinical reasoning. So we've touched on the first two. So we know that a lack of understanding could lead to a lack of patient-specific tube choice, and it risks us using the same tube or the same tube type across many patient groups rather than it actually being selected based on our intended outcomes. So for instance, a patient needs a size 7 and we use the first size 7 that we see on the shelf rather than actually considering what specifically we want to achieve with that tube. Again, we've discussed that it could lead to incorrect provision of emergency equipment. But then if we look at the last 2 points on there, so you've got the potential that inappropriate tube selection could increase the requirement for tube change, where this could have been avoided if you'd picked the right one first. So for example, you've got a patient that's got a size 7 twist in. This allows adequate ventilation, but because of the outer cannula dimensions and amount of the trachea that the tube occupies, the patient's struggling with progressing their weaning, and the tube has to be downsized to a size 6, something that people might be quite familiar with. Potentially, if initial insertion of a twist plus size 7 had been looked at, this would have allowed the same inner lumen for ventilation, but it would have occupied even less of the trachea than the size 6 twist would. So it potentially could have allowed that progression of weaning without actually needing an additional tube change. And obviously tube changes bring their own risks as well, if they're done sooner than we actually require to do them. In a similar way, you've got the potential of increased tube changes that actually don't achieve any benefit. So for instance, if you don't recognize the differences between twist and twist plus, then a clinician might assume that a patient struggling to wean with a size 7 twist plus would progress better by downsizing. But if you don't understand your dimensions, you might then think, I'm going to downsize them to a size 6 twist. So they might then choose to downsize to a size 6 twist. And we know by thinking of our dimensions that we've just talked about, that this actually isn't going to provide any additional space around the tube for airflow to aid a wean because of those outer cannula dimensions. So actually you could complete a tube change thinking that you're going to help a wean by downsizing, but you've actually had no clinical benefit and it's not had the desired impact on that patient's wean. So you might be completing tube changes that actually don't have that effect that you need. So that was a lot of information in a short space of time, and it very much will set the scene for the evening, and you'll get kind of more detail about these things and sort of applying them to clinical practice a little bit, I know especially from Kate in a minute. So hopefully the things that I've sort of gone over will make sense a little bit in the next talks. But a few of the main points that I just wanted to highlight are firstly the importance of knowing the impact of your tube dimensions and how potential clinical outcome can be affected and why our tube selection should be patient specific. Secondly, whilst I don't expect anyone to go away knowing exact dimensions of tubes, it's just vital that we have an awareness that tubes can differ considerably even within the same brand. So when making any tube changes or considering changes, it's really important that we do access that information and familiarise ourselves with the data and make sure that decisions that we're actually making are going to have the influence that we intend them to have. And thirdly, hopefully the things we've discussed will just get you thinking and questioning things, just thinking about the clinical reasoning behind why each of your patients has the tracheostomy that they do, potentially what changes in presentation or goals might initiate a discussion around if the tube needed to be changed to something else in the future. So if we can continually question things in practice, it will make us better clinicians. It will help everyone's understanding. And that is it from me. So if there's any questions, shout. We're 1 minute over time, not too bad. But feel free also to hold on to any questions just to see if they are answered in the next couple of presentations, because they may well be answered in a little bit more detail by our clinicians. And then we might have some time at the end as well to go back to them if they obviously are not answered. So I'll just give you a couple of seconds. Check my Q&A. Cool. So if any questions do come through, I'll bob back to them after if they've not been answered by Katie's talk. But I will introduce Kate to you now. So we have got Kate, who's got 13 years experience as a physio, nine years experience as a specialist in the respiratory field. I'll interrupt that really quickly. The technical data for the tubes is available on the ATOS website, and if you, when we send the recording out, And attached to these slides on the references, I've got a link to it, but you can go on the ATOS website and you'll find all the instructions for use and technical data on there for our tubes. So we've got Kate, who's got 13 years experience as a physio, 9 as a specialist in respiratory. She's currently the clinical specialist in critical care and respiratory at Mid and South Essex, and is an active member of the critical care unit senior leadership team. And Kate's got a special interest in complex and prolonged ventilator weaning and early rehab. So Kate, the slides are all yours.
Thank you. So we've gone through it a little bit, so I'm just hopefully going to go into it a little bit more detail for you guys, and if you have any questions, please just write them as we go, and I will try and answer them as best I can. So just in brief, great sources of information. There's always a lot of information out there, and I just wanted to signpost you guys to kind of, in my opinion, the place where the best information comes from. And that's the National Tracheostomy Safety Project, which is a huge project that's done nationally, and has a vast amount of information that you need with regards to tracheostomies. Your Global Tracheostomy Collaborative, your Intensive Care Society tracheostomy standards, and your FICM standards as well. They're always a great source of information. So considerations for tube selection. Previously, standards were that your tracheostomy tube shouldn't take more than 3/4 of the lumen of your trachea. The problem with this is that there wasn't really any evidence out there to suggest why that was the case or why that was the guidance. And they also didn't provide any guidance on how to measure your trachea. So this has now come away or come out of the guidelines. It was removed in the FICM and the ICS guidance for tracheostomies in 2020, sorry. And they now just recommend that there should be a balance. So there needs to be a balance for ventilation breathing through a tracheostomy tube when the cuff is up and when it's inflated, alongside the desire to allow airflow around the tube when the cuff is deflated, as well as for the use of a one-way valve, which I'll go into more detail a little bit later on. Other things that we need to think about is that the smaller the inner cannula diameter is, the more the air supply is reduced. So this makes the effort required for breathing greater. This kind of goes alongside what you've already learned, and we'll go into detail a little bit more when we're looking at the tubes and what tubes we want to consider and why. Every millimetre counts. I can't emphasise that enough. We see it I work on the critical care unit, and we see it time and time again that literally every single millimetre that you can gain really does count. So it's really important that you know the dimensions of the tubes that you're using for every single tracheostomy that you have in your area of work. There is always going to be a compromise when you're coming up with your tube selections. You need to compromise basically between the desire to maximise your functional internal diameter. This in turn will reduce your airway resistance and your work of breathing. So when it comes to weaning, this will help massively. But you also need to try and limit the outer diameter to facilitate the airflow through the upper airway when the cuff is deflated. And it is really about compromise, and it's about your patient, and it's very patient specific. So my advice is always look at your patient and determine what it is that they might need more of in order to find that happy balance and that happy compromise, because through experience, no patient is ever the same, no matter how much you expect them to be. I can guarantee not one single patient ever responds the same way as another, unfortunately. So then we need to also consider kind of the tube length of your trachees. So everyone thinks about kind of inner diameters and outer diameters, which is great, but you've also got the tube length that you must consider. Variations in the length have big clinical implications. A tube which is too short can carry a high risk of accidental decannulation, which obviously we don't want to happen. And they can also sometimes cause partial airway obstruction due to the poor positioning of the tube. On the flip side, too long, and you may end up impinging on your carina, and this can lead to a lot of discomfort for your patient and a lot of coughing usually. So you want to find the right length for your patient. Standard length tubes are normally designed to accommodate patients with normal airway anatomy. The ideal length of a tube should be so that the tube sits a few centimetres above the carina. But again, there's no guidance on this. But we also need to think about the angulation of the tube, because the standard tracheostomy tube may be too short and it may be unsuitable for your patient. And I am more than certain that anyone that works in ENT will know that far more than I do. But it may be that you need to then look at other tracheostomies that provide the extra proximal length. And these are normally for patients that either have a deep set trachea, so those that have a large neck, goiters, a neck mass that's in the way, or patients that have tracheal problems, so those that might have tracheal stenosis, should potentially be considered for an extra proximal length tracheostomy. As I said earlier, knowing your dimensions is absolutely key. And I know we've gone through this in a little bit of detail in the previous slides, but me as a clinician really wants to kind of hone in on knowing what your dimensions are. Unfortunately, no matter what brand of tracheostomy you use, there is no standardized size between manufacturers. So what this does is it causes a variation in the sizing of not only your inner cannula diameters, but also your outer diameters. And this is even when you're referring to your standard trachea sizes that we all know of, like your 7s, 8s, 9s. And this does cause a lot of confusion. And I can't count on my hands how many times I've had to have the same conversation on the unit that I work in, that a size 7 doesn't necessarily mean that you've got a size 7 inner diameter. So some tracheostomies have a better inner cannula to outer cannula ratio, which in turn gives you the best airflow. And remember what I said, every millimetre counts. So ideally what you need to do is you need to get the best compromise with that tracheostomy that combines both the smallest outer diameter with the largest inner diameter to give the best possible airflow, reduce the amount of work of breathing for that patient, and reduce the amount of resistance as best you can. This in turn will help with ventilation, weaning, speech, whatever it is that you're trying to achieve with your patient. If you look on the slide, you will see that we've got tracheo twists, we've got tracheo twist pluses, as we've already gone through. And I've also put Shileys and Portexes on there just from past experience of the use of those tracheostomies. And this is where I have to really hone in on knowing your dimensions. So if you look at, for example, the tracheo twist, we're going to go with an 8 because they all have an 8 as standard. So if you look at your tracheo twist size 8, the inner diameter is a size 8, which is brilliant. That's exactly what you need. And the same for your tracheo twist plus. But as Elena said earlier, the outer diameter is different. So for your twist, your outer diameter is actually 11.4, whereas your twist plus, it's only 10.8. So you are gaining millimeters if you go for a twist plus, and you're actually creating bigger space and bigger airflow around your tracheostomy, especially when you're trying to wean and provide a one-way valve and things like that. So it's definitely worth considering. If you then look at your Shileys, your 8 actually only provides an inner diameter of 7.6. So although it is a size 8, the inner cannula isn't a size 8, and the tube is actually quite a lot thicker. So you do lose some spacing depending on the brands that you use. And again, if you then look at the outer diameter of the Shiley, it's a lot bigger than the tracheo twist or the tracheo twist plus, and it sits at 12.2. So you have got a much bigger diameter outside and a much smaller diameter inside. So you've had to compromise quite a lot with that tube, which is worth considering when you're looking at what tracheostomies you're choosing and why. And then you have the Portexes as well. So the Portexes Blue Line, which we previously used in our trust, they say that the inner diameter is a size 8 in millimeters. But what you need to be aware of is that they are measuring the inside of the outer diameter. So at that point, they haven't got the inner cannula in situ. Once they put the inner cannula in situ, the inner diameter actually reduces clearly, and it goes down to 6.5 mil. So the true spacing of that inner diameter for a Portex Blue Line is only 6.5. And again, the outer diameter is 11.1. So it's still greater than your Tracheo Twist Pluses and still slightly greater than your Tracheo Twists. So it's just important that you know your tubes and that you're aware of the actual sizing, because picking a size 8 doesn't necessarily mean you're getting a size 8 inner diameter. So it's really, really important. Really important. There's also, you also need to make a note of the length of the tubes. As we were saying, tubes that are too short can cause an issue, and tubes that are too long can also cause an issue. And the lengths also vary depending on the type of tracheostomy or the brand of tracheostomy that you are using. So your Tracheo Twist size 8 is 76 mils. They're all roughly the same size. Your Shiley's are 81, your Portex is 75.5, but your Tracheo Twist Pluses are slightly longer. And in our trust, we particularly like that they're ever so slightly longer, because we seem to be having less complications with them, which is a great thing, really. Honing on the fact that I work in critical care, so when we're providing tracheostomies for patients, ventilation tends to be the biggest focus for us at that point in time. So we tend to go for the larger tube for our patients, and this can sometimes cause distress to our patients, especially when they're not able to talk or when they're not able to get the cuff down and use a one-way valve. So you just need to really consider what size tube you're using and what is the best fit for your patient. On the flip side, you don't want to choose a tube that's too small, because then the cuff needs to be overinflated, and that can also lead to complications. So you really need to know your tubes in order to get the best fit for your patients. I then just briefly want to go into a case study. This is actually from our unit, but I've taken most of the data and things out just to make it a little bit easier. We had a 67-year-old woman who spent 32 days on our critical care unit following a community-acquired pneumonia. She had prolonged ventilator weaning, and at this point she was now off the ventilator and on high flow, and we were looking at trying to decannulate her. The patient had a size 7 Tracheo Twist Plus tracheostomy in situ. It was cuffed, it was unfenestrated. And she was able to tolerate cuff deflation, but she had very minimal airflow into the upper airway despite the cuff being down. Because of this, the decision was made to downsize her to a size 6. So they downsized her to a size 6 Tracheo Twist. It was still cuffed, just in case she needed to go back on the ventilator, and it was unfenestrated. What I want you guys to just have a very quick think about is, what would the clinical reasoning be for the downsizing? Why was it that they chose to downsize this lady's tracheostomy? This tracheostomy downsize actually didn't work. I want you to think about the potential reasons why this didn't work, and then also think about what else could have been considered instead of downsizing this patient's tracheostomy. And I'll literally just give you 30 seconds if that's okay. And I'm going to talk through it. I know it wasn't very, very long, but I know that we're very pressed for time today. So the clinical reasoning for downsizing the trachea, the reason that when I asked why we downsized was because we wanted to allow for more airflow, which is normally the reason that we choose to downsize a tracheostomy. So she's struggling to get airflow around the tracheostomy that's in place. So downsizing it, in theory, in their heads, you're going to reduce the outer diameter of your tracheostomy, which then allows more airflow to go up into the upper airways and more airflow. I just want to remind you of the fact that although by downsizing you can create more airflow around the tracheostomy, you've also got to remember that by downsizing you're making the inner cannula smaller, and that in turn then reduces the air supply, and it makes the patient have to work harder, and their work of breathing increases, and that effort for patients is usually a lot more difficult, especially for patients that have been prolonged weaned, that are generally weak, have spent a lot of time in critical care. And people tend to forget that the downsize aspect is great. We're getting more airflow potentially around the tracheostomy, but just remember that you're also making them work harder when you're not generating that airflow around that trachea, if we're putting that cuff up for any reason at all. The reason for me why this tracheostomy downsize didn't work is because, as previously discussed, we went from a TracheoTwist Plus to a TracheoTwist. So again, it was more about the fact that there was limited awareness of the differences in sizing, and they just thought TracheoTwist, great, let's put it in, and didn't quite realise that we carry two slightly different tracheostomies on our unit, and they do have a change in sizing. So what we ended up doing was we only increased the outer diameter by 0.6 mils. Every mil does count, but 0.6 mil is tiny, and we didn't actually generate much additional space at all. And just by generating that space, we've made that work of breathing harder, we've increased airway resistance, and we've not really achieved anything. And in turn to that, we've reduced the inner diameter by 1 mil. So we've made it a lot harder for this patient, and she did unfortunately end up having another tracheostomy change, just to try and achieve the goal that we were looking for. So when we're considering what else could have been done instead, for me, the first question that I had was, does this lady still need ventilation? If this patient doesn't need ventilation, is there a need to replace it with another cuffed trachea? There are reasons that I'll go into detail more further along on my slides, and there are reasons that we would consider still putting in a cuff trachea, but we need to ask ourselves that question: did she need a cuff? And if she didn't need a cuff, could we have gone with an uncuffed trachea just to try and generate a little bit more space around the outside? And it's controversial, but could we have gone down a fenestration route? So could we have used a fenestrated tracheostomy? For me, I'm very opinionated. Fenestration does have its place. It's minimal, but it does have a place for us as clinicians and for us within intensive care. And for me, this would have been a scenario where this potentially should have been considered for this patient, just to try and reduce the work of breathing and make our lives a little bit easier. So sizing does matter. What we also didn't consider was the fact that the tube was much shorter. As I showed you earlier about the lengths around the tubes, your TracheoTwist Pluses are longer, and your TracheoTwists are shorter. And because you've also gone down a size, they are shorter. So I think it works out about 13 mils difference in length, which is quite significant. So you just need to also be aware kind of the length of the tubes when you're changing them as well. So other factors that influence tube choice, we're going to go through each of these factors in slightly more detail, so I'm not going to go through them now, but ideally we want a tube that allows for optimal ventilation, suctioning, communication and weaning, with the overall outcome being for decannulation. I say we, I work in critical care, so that's what our aims are. Other environments have different aims, different goals, and may choose tracheostomies for different reasons. But that's what we look for when we're looking for tracheostomies within the intensive care unit for the majority of the time. And all of these factors need to be considered when you're choosing the most optimal tube for that specific patient. So don't forget to look at things like your patient's presentation, the reason for the trachea, what the goal is. For me, that's really important. We forget about what the goal is for that specific patient. What clinical environment you're in, make sure it's MDT approached, cuffed or uncuffed, fenestrated, unfenestrated, single or double lumen. Do you want a subglottic port? Does it need to be an adjustable flange? And they all need to be considered before you put that initial tracheostomy tube in, just so that you try and optimize the patient right from the word go, really. So patient's presentation and the reason for their tracheostomy. So for me, we always need to look at their respiratory function. On critical care, the majority of the time, there still needs to be a degree of positive pressure ventilation. So for us, we always used cuff trachees, or for the majority of our patients, we used cuff trachees, and in different environments, this would be different. But for us, it's needed. It is recognised that you can ventilate, you can mechanically ventilate long-term tracheostomy patients through an uncuffed tube in certain circumstances. But because we're kind of at the start of that patient's journey, all of our patients start with a cuffed trachea on the critical care unit. You also need to think about kind of the abnormal airway of the anatomy, and have they got an abnormal airway for that specific patient. If patients have obstructed upper airways, they're sometimes at risk of particular tracheostomies becoming obstructed or misplaced. For us, any abnormal airway gets referred, so they get referred to our consultants, who then may look at considering whether they need a surgical tracheostomy rather than a percutaneous tracheostomy. And then the tube choice kind of falls out of our hands and goes into the expert's hands with the abnormal anatomies for those patients. They may also decide that the choice of tracheostomy tube that we have on our unit isn't good enough. So sometimes we will have patients that come to our unit with a completely different tracheostomy tube in, because that's what they have decided to use, and then we just have to work around it when it becomes to the point where we're weaning off a ventilator, trying to provide swallow, speech, all those added bits in. It may be that we have to then refer back and ask, can we change them to this? Are you guys going to change it? Are we? So you always need to make sure that you're aware of who has done the tracheostomy, and are they under a specialist team for whatever reason. Think about your clinical environment. Every tracheostomy is chosen based on the environment that we are in. So we may choose to have a cuff trachea, but a patient in the community may choose to have an uncuffed trachea. A long-term trachea may be uncuffed. So just think about where you are and why. And I go into this in a little bit more detail a little bit further along. Think about what your goal is for your patient. This is huge. So if their goal is to wean off a ventilator, to be able to speak, be able to eat and drink, and to be able to rehab, then they have got completely different goals to someone whose goal may be that they need to optimize suctioning and they're going to be a long-term trachea. So just think about what it is that you specifically need for your patient and what your overall aims are when you're choosing what tracheostomy tube you're going to use. And underneath, I've just put what the 3 most common reasons for a tracheostomy are for us on our unit. So we use a tracheostomy if we need to bypass an obstructed upper airway. We may choose to do a trachea to remove secretions from that airway, or our main reason is due to prolonged dependence on ventilators and prolonged weaning. My last bit about patient's presentation is just ensuring that you've used the MDT. Obviously, I'm biased, I'm a physio, so we need you to use the MDT, but we may have very specific preferences on tube choice for very specific reasons. So a patient, for example, may be off a ventilator, and we don't feel that they're going to need to go back onto that ventilator. So they no longer need positive pressure ventilation. So I can understand the reasoning to go, well, do we need a cuff trachea? But speaking to your physiotherapist, they may turn around and say, we're really struggling with secretions. And actually what we're doing is we're providing manual hyperinflation, and that cuff will just allow for better manual hyperinflation. So they may ask for a cuff for a very specific reason. So just make sure you've asked your MDT what tube they feel that we should use as well and why, because they may have very specific preferences for very specific reasons. Moving on to your clinical environment. So just think about that the clinical environment will have an impact on choice. Ward staff, for example, can change inner tubes very easily and very quickly to relieve obstruction of secretions. So if any of our patients are going to the wards, we always make sure that they're double lumen. We use double lumen tracheostomies consistently through our critical care unit. And that's just because that they're considered to be safer. If you have an obstruction, it's very, very quick to change that lumen and that inner cannula for a nice clean one. Whereas if it's a single lumen and it gets blocked, you need to be in an environment where you can have a very quick, complete tracheostomy change. You also need to think about your clinical environment because of the tubes that you have. Tubes can get very complicated. You can have subglottic ports, you can have balloon pilots for your cuffs. single lumen, double lumen, and there's potential for more confusion the more bits and components you have for your trachees. So if these tracheostomy patients are going to the community, or they are in the community, it may be that you opt for a more simpler tube just to prevent less confusion. You'll be surprised at how easy it is to accidentally clip something onto a different line than what you think it is if you don't know what it does. So you just need to consider what clinicians you've got in what area that you're using. And you always need to have a balance. You need to balance the risk of cuffed tracheostomy tubes, and base that on the environment that you're in. So I've gone into this a bit already, but just make sure it's an MDT approach. Everybody has specific skills for specific reasons. So you just need to take those things into consideration. For me, the questions you need to be asking is, what are their secretions like? Are they easy to clear, or are they thick and difficult to clear? What level of chest physiotherapy are they having, if they are having any? And what chest clearance techniques are we using to try and clear those secretions? You also need to ask yourself about what weaning structure is going to be used. I'm very, very pro of getting that cuff down as early as possible on the critical care unit, and I can't emphasize that enough. So in order to get that cuff down, you need a really good choice of tube, and so you just need to consider what weaning strategies you're going to use. We love a one-way valve with physios. We always love a one-way valve, and we like to get that in on the ventilator circuit with cuff down as early as possible. So you need to make sure, or we need to make sure, that we choose a tube where you've got the smallest outer diameter possible, but with a good fit, so that then when you are putting that one-way valve in line with the ventilator circuit with cuff down, that you're getting adequate airflow up into the upper airways. So we always consider that when we're looking, especially for our prolonged wean patients. You also need to think about what their swallow's like, so please involve your speech and language therapists. They are amazing, and they'll be able to tell you exactly what's going on with their swallow. And you also need to think about what communication and speech modalities you plan on using for your patients when you're choosing your tracheostomy. So please incorporate the MDT when you're just deciding what tracheostomy to use. So cuffed, uncuffed. As I said earlier, you need to think about whether there's a degree of positive pressure ventilation that's going to be used. If there is, you're going to need a cuff tracheostomy. That cuff is going to fill your tracheal space around your trachea, which is going to prevent that airflow escaping through the upper airway. So please think about whether you're going to need it and why. For uncuffed trachees, ideally your patients are going to need an effective cough and a gag reflex to protect themselves from aspiration. Secretions can also impair your airway patency, and patients may not tolerate a deflated cuff or a cuffless trachea. So you also need to consider that. It may be that they don't need positive pressure ventilation, but actually they've got copious secretions where they are just pooling, and that may be that indication for that cuff tracheostomy at that point in time. So please think about having a look at the cough reflex, the strength, and how at risk they are of aspirating as well. It was touched upon earlier, but there are misconceptions around the cuff and that it prevents aspiration. You've already aspirated if anything is sitting on that cuff. It's already past those vocal cords. And I'm not a speech and language therapist, so I'm not the best one to comment on it, but at that point you have already aspirated. The cuff does minimize aspiration, however, of your oral and your gastric secretions, but it doesn't provide a complete seal. So there isn't an absolute barrier to this, which is worth considering when you're thinking about your tracheostomy tubes. So think about your secretions, as I've spoken about earlier. Think about your uncuffed trachees for your patients that are those long-term patients that are potentially going into the community that are needing ongoing suctioning, or those that are going to the wards that need ongoing suctioning. When thinking about your cuffs, think about the risk of the tracheal damage. Do they need a cuff? Do they not need a cuff? Overinflating a cuff can cause tracheal damage. So that's when your sizing and your dimensions are really, really important. So just bear that in the back of your mind when, if you are choosing a cuff trachea, make sure you're optimizing that cuff inflation pressures. On the flip side, your uncuffed tubes can aid your swallowing and your communication better. They provide more airflow, as our case study showed. So just think about whether or not it's absolutely vital, whether they need a cuff or not. And also just think about whether or not you're going to be using speaking valves to communicate. Speaking valves can be used with cuffed and uncuffed trachees. You just have to remember that the cuff must be down if you're using it on a cuffed trachea. And that's really, really important. It's also important to note, just because you've got a cuffed trachea with the cuff down, it still might not be safe to use a speaking valve or a one-way valve. You have to have airflow into the upper airway and through the pharynx. If you haven't got that, it's not safe to use a one-way valve because you have got nowhere for that airflow to go. So don't think, yes, the cuff's down, so we're okay. You need to make sure that they've got adequate airflow bypassing the tracheostomy and up into the upper airway before you consider putting a one-way valve on. And then just think about your patient setting again. It depends where you are, what setting you're in, whether you're going to use a cuffed or an uncuffed tracheostomy. But inherently, it's safer to use an uncuffed tracheostomy in your non-specialist locations, because if the tracheostomy becomes obstructed in any way, you've at least normally got some airflow going to the upper airway that can then bypass it, that will get you out of trouble. I've just put a lovely picture in there just to emphasise the two different routes of airflow and the impact of your size of your tracheostomy tube. So just make sure that you've got airflow going around that tracheostomy for whatever reason, if you're using a speaking valve or if you're trying to wean a patient. Fenestrated or unfenestrated, you need to think about what tube you're using again and why. Manufacturers don't recommend the use of fenestrated tubes at the time of a percutaneous tracheostomy, and that's from the ICS guidelines. There's also needs to be huge caution if you're mechanically ventilating someone with a fenestrated tracheostomy due to the risk of surgical emphysema. Even if you've got a non-fenestrated inner cannula in place, the use of a fenestrated tracheostomy tube isn't usually recommended. So you just need to think about where your patient's journey is at that point in time as to whether or not you should be using a fenestrated tube. Fenestration is sometimes poorly positioned, so it's sometimes poorly positioned near the posterior tracheal wall. And this can irritate that wall and increase that risk of granulation. This can then grow and occlude the fenestrations, and it sometimes makes it difficult to pass your suction catheter, and it also complicates the removal of the inner cannula and can sometimes complicate the removal of the tracheostomy itself. So that needs to be in the back of your mind when you're deciding whether you need a fenestrated tracheostomy or not. All of our tracheostomies on our unit are non-fenestrated, and we only use fenestration for very specific patients for very specific reasons, and it is always an MDT-led decision based on that specific patient. There's also some papers out there which I've put in my references just because I like a good debate about fenestrated trachees, and there is some evidence that's demonstrated that fenestrated trachees actually can cause more complications. I think the percentage is 56% versus 16% for non-fenestrated trachees. So please have a look at the references. Sometimes they are quite a good read. You also need to consider your patient's work of breathing. So as I said earlier, fenestration does have a place. It really does have a place for use for specific patients. And there is evidence that shows that fenestrated trachees provide less work of breathing, especially when the cuff is deflated. So that also needs to be in the back of your mind when you're trying to aim for weaning for your patient. If work of breathing is an issue, will fenestration help? And there are cases where it does and there are cases where it doesn't. So it is quite patient specific. Also think about your cough strength. It's always important to identify what your cough strength is doing. And just please bear in mind that you do not need fenestration, a fenestrated trachea when you're using a speaking valve. So you can use a speaking valve or a one-way valve with a fenestrated trachea, and you can use one without. we wean the majority of our patients cuffed and non-fenestrated. Cuff goes down, speaking valve goes on, and we're able to wean them without a fenestrated tracheostomy. But as I said earlier, there are some cases where you may need to use a fenestrated tube, so just bear that in mind. You also need to think about single or double lumen. I love a double lumen tracheostomy. It's inherently safer, especially in the environment that we're in, but especially in the community as well, whereas you can take an inner cannula out very, very quickly. You just have to bear in mind that with a double lumen, inserting an inner cannula does decrease the usable space, and it does create more resistance and more work of breathing. So it's a consideration that you need in the back of your head when you're considering it for your patients. The ICS 2008 guidelines recommended that single lumen tubes should not be routinely used in our critical care units due to the risk of occlusion, and we don't use any single lumen tubes on our unit at all. But they do have a place, just not where I work, unfortunately. Think about your subglottic ports. So I've put on our slide that it may inform practice. We routinely use subglottic ports with our patients. We routinely measure the amount of subglottic secretions we're getting hourly from our patients. And for us, this does help inform our practice. We go with 5 mils. So if you're getting more than 5 mils an hour via your subglottic port, we are more cautious about putting the cuff down than someone that is getting less than 5 mils an hour via their subglottic port. But I do want to emphasize that this isn't the be all and end all. It informs our practice and helps us clinically reason whether or not we're going to put somebody's cuff down or not. But if they are on a ventilator and you're looking at putting cuff down and potentially a one-way valve in situ during ventilation, the pressure of the ventilator can actually aid the removal of those secretions that would be sitting above that cuff. And there is evidence out there to show this. So it does inform our practice, but it's one component of many that helps us make those decisions. There's evidence to suggest that subglottic suction can reduce the incidence of ventilator-acquired pneumonias. So we do routinely use it on our unit. But as I said before, we're a critical care unit. So if you're in the community, you may choose not to have a subglottic port because it's just one extra thing that you have to worry about and that you have to train staff on. And the more simpler you make the device, the better. I have heard a horror story once where a feed was connected to a subglottic port. So you will be surprised at what can be attached onto ends of tubes when people aren't aware of what they do. So you do really need to think about the environment that you're in if you're considering using subglottic ports. And then one-way valves, I have to put one-way valves on there. One-way valves are a wonderful thing, and they can aid your cough strength, they can aid communication, they definitely aid weaning, but you must have airflow into the upper airway, as I said earlier, and they can be used with cuffed and uncuffed trachees. Just make sure your cuff is down, and they can be used with fenestrated or unfenestrated trachees. For me, when you're considering what tube you're going to use, you need enough airflow around the tracheostomy for the one-way valve to work. But you also need, if you're doing it via a ventilator with cuff down, with it in line, you also need a good diameter, inner diameter as well, to allow for good enough airflow and reduce the work of breathing. So that compromise that I was talking about right at the start with minimizing the outer diameter but maximizing the inner diameter really comes into play when you're looking at using those one-way valves, which is why making sure that you've got the correct size for your patient is really, really important. And then I thought I'd pose a question to you guys. This is a project that we did on our critical care unit back in 2020. Does tube size matter? We merged as MSE Basildon Southend and Broomfield Hospital back in April 2020. The senior leadership team wanted to look at trachees. We were using Portexes and Shileys at that point. I loved tracheo twists, and some of the leadership team also preferred tracheo twists. Southend and Broomfields were also using them. So we thought, let's do a little project, let's change trachees and actually let's see if it does make a difference to our patients. So what we did was we collected data from the last 6 months of admission, retrospectively for all our patients that had Portexes and Shiley trachees in. And then we changed to our Tracheo Twists, Tracheo Twist Plus, and then we collected 6 months of new data. And I've put the little table up there for you guys to show you how many patients we included in our study. We excluded 13 from retrospective data and 10 from the new data. And these were patients that were either going to be long-term trachees, repatriated to other hospitals because we couldn't follow them through, or patients that unfortunately passed away. So we ended up with 16 and 15, which was quite nice. And then these were our results, which was quite surprising. So the average time to decannulation reduced by 24% for our patients just by changing from one brand to another. And our average length of CCU stay reduced by 23%. It also impacted our hospital length of stay, which we were quite surprised at. This reduced by 17%. And interestingly, previously, all of our patients, 75% of our patients required a tracheostomy change, compared to only 20% of our patients needing a tracheostomy change once we changed to the Tracheo Twist Plus tracheostomies. This also then led kind of hand in hand with a reduction of single-use plastic and by 55%, which is substantial when we're trying to think about the environment and we're trying to show that we're being considerate to our environment, which is something else that we don't tend to really think about. For me, does tube size matter? My answer would be yes, it does matter. I am in the process of writing this up. I feel very strongly that if you can optimize your inner cannula space whilst optimizing your outer cannula space and your outer diameter and getting that best compromise for the patient, then you should hopefully be able to wean quicker, decannulate quicker, and hopefully step your patients down a little bit quicker. And I'm glad that we've been able to show that. So your choice of tracheostomy tube does really matter, and it does really impact the patient's journey, and it affects their quality of life. If they spend longer on a critical care unit, their mortality and their morbidity will increase. So if we can actually reduce their length of stay just by making sure that we choose the right tube for our patients, then I think we should actually take longer to decide what tube we're going to use when we initially put one in order to try and benefit them as best we can. And then key points to take away. I just want you guys just know your tube sizes. That's really, really important. Know your dimensions. This plays a massive role, especially within a critical care setting when you're trying to push absolutely everything, especially for your ventilator weans and your tracheostomy weans. Every millimetre does really count. Ensure that your care is patient-centred. What are your goals? What's most important to them? People tend to forget that, and they think that speech is always the most important thing in communication. And sometimes they might say to you, all I want is a drink. So think about what it is that they want to achieve and how you're going to help them best to achieve it. Make sure it's then patient specific and clinically reasoned. When you're changing your tubes or when you're picking your tube, make sure you've clinically reasoned what you've chosen and why. And please make sure it's an MDD approach. Honestly, the speech and language therapists are amazing. The physios, I'm biased, but they're amazing. They've got a lot of clinical knowledge that can help with that decision, and it just stops complications further down the line or unnecessary tube changes. I have then put my references in, so please have a read of them. They're quite interesting reads. And then I think that is it for me, unless anyone's got any questions.
Thanks, Kate. That's brilliant. There was a question that came up earlier that probably fits in best with yours, actually. So did you find patients tolerate the length of the Twist Plus okay? I think when you're doing your QI, that's probably quite a good question that fits in with yours.
Yeah, we haven't found any problems with the extra length. our consultants are quite keen on a slightly longer tracheostomy tube. Obviously, we don't want it so long that it hits the carina and causes discomfort and coughing, but you want a tracheostomy tube that fits really nicely. And we have found that with the Tracheo Twist Pluses. Every now and then, we do carry both Tracheo Twists and Twist Plus. And the reason for that is you will every now and then get a very tiny little old lady, and the consultants will look at them and they're 100% right. They're not going to tolerate that Tracheo Twist Plus. So they go for a Tracheo Twist. And that's where knowing your dimensions is really, really important, because if you haven't got that awareness that a Twist Plus carries a slightly longer length, that may be where you then lead to complications. So that's why we carry both. But we haven't found any problems with the Tracheo Twist Pluses, but you need to be aware of the length to begin with.
Perfect, thank you. I'm going to put this one to you as well, actually. What are your thoughts about fenestrated subglottic tubes as a first line insertion? Sometimes we get questions about people that want to use subglottics, but they want those fenestrations just in case.
Yeah. I'm very opinionated. In my opinion, I would be asking why you're going for a fenestrated tube to begin with. Part of our project, we used to use Portexes as our first line, and then non-fenestrated, and then we would change to a Shiley fenestrated, and that Shiley would then go to the ward with them if they step down with a trachea. The question is do you need that fenestration to begin with? It was a massive QI project for us, because we had lots of nurses and lots of clinicians arguing with us that we wouldn't be able to wean unless we had that fenestration. And we were able to show that we were actually able to wean without fenestration, and in my opinion, more effectively. They only needed one trachea. We showed that we reduced their length of time to decannulation, and we showed that you can wean easily without that fenestration. Fenestration does have its place. If you've got a tiny little old lady and she's really struggling with airflow around the trachea when the cuff's down, it may be that you then say, okay, let's do a trachea change for fenestration, or let's do it to reduce work of breathing. But most of our patients, a majority of our patients are weaned, cuffed and unfenestrated. And I think that's where your tube choice really comes into play. If you're using Portex, for example, you've got a tiny inner cannula diameter and a big outer cannula diameter, whereas the Tracheo Twist Plus, you actually optimize both, which is why I think we were then able to wean with unfenestrated trachees. It does have a place, but you are able to do it without it. So why put it in to begin with if you haven't tried?
Very good point. I think that probably answers the other, because there was another question that popped in about when you'd use fenestrated or unfenestrated tubes, but I think through your whole presentation and that we've sort of covered that. But if anyone's got any further questions on that, just pop them in the Q&A, but I will quickly move on. So thank you so much, Kate, that was brilliant.
Thank you.
We will move on to James. So I will introduce James, who's been a consultant for 8 years, and he set up the tracheostomy and laryngectomy team in Wolverhampton after he started his current role. So the team is now well established. They've got a variety of staff, regular meetings and clinics, as well as undertaking regular training days. They complete trachea ward rounds and deliver care in both the hospital and community, as well as having taken the clinic to a nursing home as well. And I did see a nice newspaper article, I think, about that. So if anyone's interested in that, if you Google it, you might find it. So James, over to you.
Thank you very much. Can you hear me okay?
Yeah, can hear you.
That's great. So thanks very much for the opportunity to talk tonight. I'm an ENT consultant, and we sort of set up this team of people which have developed further and further as the years have progressed, and now we're at a stage where we've got a bit of experience about our tracheostomy patients. I'm obviously a surgeon, and my sort of experience of tracheostomy patients is probably a little different from Eleanor's and Kate's. Our community experience is the thing that's really opened my eyes up to patient choice about tracheostomies, and hopefully I can talk about some of that going forward. So let me just work out. Yeah, so there we go. We're going to explore some of the ENT specific considerations and our team's considerations for different tracheostomies. We'll touch on some of the weaning and weaning decision making and whether actually patients are able to be weaned or not, because in the community, many patients have well-established tracheostomies and weaning is sometimes possible, and the question has never been raised, but sometimes it's not possible at all. And we're looking for an optimized situation in each of those individuals. Already touched on the fenestration versus non-fenestration issue. I'll touch on that as well. And then very importantly, we'll go on to some patient examples and some of the difficult decision making that's required. Kate, I really liked your final slide that summarised the most important factors to consider for tube choices, and I agree with all four of those points. It must be an MDT decision. The patient must be the centre of the decision making as well. And obviously the patient is very much part of the MDT. So, and this is really apparent, especially in the community for decision making. So obviously there's a lot of physiological considerations to make, but in the end, actually the patient makes the final choice, especially when they're competent to do so, and you give them as much information as you can. I'll touch on how it works in our establishment, and we'll go on to some questions. So what does the patient actually need? So we've Kate and Eleanor have already talked about some of the clinical indications. So particularly from an ITU point of view, when patients are in ITU, sometimes it's fairly obvious what patients will require. They have an endotracheal tube in. Often we go for a very similar size, and that's what's inserted either percutaneously or via surgical tracheostomy in theatre with us guys. In the ICCU environment, patient preference is often minimal, and it's fairly understandable why that might be. Frequent visualization is really important. So nasal endoscopy and endoscopic assessment of swallowing is important, just to see what's regularly to see what's happening with the upper airway, and also visualization via the tracheostomy as well, to see where the end of the tube sits, because as you've seen during the presentations this evening, the tube sizes are vast, but that's because patient sizes are vast and patient dynamics are different. And patient sizes are hugely variable, both in the thickness of the neck, the length of the trachea, the width of the trachea. There's a lot of considerations to make, and sometimes we just make a best guess and see what happens. And if there's a problem, then we may need to change the tube based on what their physiology is and how they start to improve. The position of the end of the tube is one of the most important things to establish. So as has been highlighted, there are some real advantages with the TrachoTwist Plus tube, in that it has such the ratio of outer diameter and inner diameter is favourable to the patients, but there is an extra length consideration, and sometimes the ventilation may be optimized by having a slightly shorter tube rather than ventilating either the left or right lung. So there's a huge amount of consideration to all of this, even in ICU. What we've noticed, especially in Wolverhampton, I'm not sure what that says about our population, but changes in body habitus are upon us, and so thicker necks are a big thing. So in our establishment, we use adjustable flange tubes a lot. I'm not sure what everybody else's experience is. By the way, I'm very keen for people to engage in conversation with all of this. None of this is very much evidence-based as the previous two talks. This is just our experience. But adjustable flanges are increasingly used, and especially for head and neck reconstruction, and some of the patients that are coming through with laryngeal cancer, and the like, and mandibular resections. We're using adjustable flange tubes almost more than any other tubes, because we need that extra length because of the distance. Further considerations are what steps are needed for weaning, and some the obvious questions that are related to that. So when we go on to weaning, when we see a patient either in the hospital environment on the wards, or when they come to our ENT clinics, the factors we consider are no different for any patient, really. We always ask the same question, whether a patient can be weaned or not, because very commonly the question hasn't firstly been asked, and secondly, things change. So that a patient who may not have been weanable for quite some time may suddenly become weanable, and so it's important to keep on asking that question, I think. Visualization of the upper airway and assessment of what's happening with the upper airway is absolutely vital. Establishing where the end of the tube is and what's happening around the tube is also really important. So asking whether what the airway patency is like, one-way valve and finger occlusion, and speech, leak speech is also important, and that's why we use our NDT to try to establish what everyone's opinion is with these sorts of factors that are all at play for weaning purposes. We ask about saliva management and oral care. Our experience in the community patients is that many patients aren't weanable, or certainly able to be decannulated because of their saliva management. I think in the past there's been a slightly wrong, for want of a better word, assumption that especially cuff tubes and larger tubes help to prevent aspiration, and as has been said before, this is clearly not the case. So rather than trying to prevent aspiration from above with a cuff, we are now really trying to concentrate on management of saliva, how to reduce the amount of saliva coming down, good oral care, use of hyoscine, use of other means and modes to try to manage the patient's saliva so that the aspiration risk is reduced, and that often really influences the choice of tube as well. The degree of humidification that patients need and how to deliver that humidification, also important things to consider. What is actually being used. So often when patients come to our community clinics, they can't necessarily communicate directly with us. So it's important to find out from the carers what's being used and how, because quite often we've found that humidification is not being considered hugely. And so we've seen Buchanan bibs used as drip collectors underneath the tracheostomy. I'm sure everyone's experienced that. And the use of valves or cassettes to go on top of the tracheostomy are not being used anywhere near enough. So these are all things that we have been experiencing. So granulations are one of the biggest factors that force us into changing the either the length or the type of tube for community patients in particular, and this is a really challenging thing to deal with. Many of our patients hold themselves into slightly unusual positions, so they've got some spasticity, some and with their quadriplegia, they hold their necks into slightly unusual positions, and the end of the tube therefore is maybe in a good position at one stage of the day, and then in a really poor position at another stage of the day, essentially occluding their tube and rubbing against the edge of the trachea. So working out how to best manage that is really, really challenging. Do you change the tube? Because you clearly can't do very much with the position of the patient. The patient will put themselves into whatever position they want, essentially. And so we found that budesonide respipules via the humidification is a good way of trying to reduce them down, and almost overdoing their humidification to try to reduce any dryness there does help, but sometimes it's not enough, and we really need to start thinking about changing the tube or the tube length, tube type, to help with their granulations. So ask questions. Are there any new products that might be more appropriate? Has something changed in the clinical course to cause the current presentation? So these are all questions that we end up asking. So I think we've really gone over the benefits and risks of fenestrated and unfenestrated tubes. Often we end up changing tubes from fenestrated to unfenestrated tubes because we see no reason for them to have the fenestrations. That's often the case. I think in the past, patients have been keen to speak and get as much air around the tube, get as much air through the upper airway as possible, but it's not, having fenestrations doesn't massively make an impact on that, we've found. So I think sometimes fenestrations can cause more confusion and more risk potentially than benefit. So I think we're moving more and more away from fenestrated tubes, but they definitely have their role, especially for the slow weaning patients and for those patients that are keen to speak early on. That's what we've found. So just some examples of the slightly unusual presentations that we get into our community clinic. This is a good one. So we had a patient that, so by the way, Emily Davies-Verrick has very kindly helped me with this presentation, and without her help for this I would be totally lost. But she's a highly specialized speech language therapist and has really opened the door to our community patients coming into the clinic that we hold every 4 weeks. She finds patients. I don't know quite whether they find her or she finds them, but she finds these patients who come to clinic with all sorts of unusual history and some very questionable decision making in the past that's been happening. So this is a good example of one of those. This patient had spastic quadriplegia and arrived on an ambulance trolley with a tube in situ that was cuffed up constantly, and with a fenestrated tube as well. So there were fenestrations there. I think it was a size 8 actually. So it was a large tube, and he was non-verbal. And we just couldn't establish why this was the case at all. We were trying to work out the carers didn't know really what the cuff was for. I think they thought that it was mainly for secretion management. He certainly wasn't using a ventilator, and there were probably more problems associated with his tube choice than not. So the history just didn't fit what we saw. So we made the brave decision to basically change the tube completely, and we've now managed to get him down to a cuffless non-fenestrated tube using a one-way valve for his secretion management, which is a much better situation. And we constantly ask, we need to, whether we should be changing the status quo, because obviously these patients have had these tubes in for quite a long time, and so they're used to their situation, and it's difficult for us to come along as as people who've never met them before to change their status quo. But it's very important that they get the best care and the safest situation possible. We have a few patients with Sylvinegus tubes, and I love Sylvinegus tubes. I think they're really, really helpful. Patients absolutely adore them. They're almost like their buddies. We have a patient who comes to us for our tracheostomy training days that we hold every 3 or 4 months, and he describes exactly why he really likes his Sylvinegus tubes. The Sylvinegus tubes, unfortunately, are no longer being made. And so what do we do with these patients? What choice do they have with regards to their ongoing tube care? So I'm just hoping that our Sylvinegus patients continue to survive with their tracheostomies, and that they look after them very much. They obviously have their engineering issues. So a number of patients have come to us needing some help with the tube itself, in that it doesn't quite fit in enough. They've either sat on it or trodden on it or something, and having Atos to help us with some of the engineering has really helped. But sometimes it's never quite the same, and you just feel that they need a new tube, but there's none available. I'm sure there's a black market out there somewhere for Negus tubes, Sylvinegus tubes. So this is this patient, third patient, is a good example of how difficult it is to deal with granulations at the end of the tube. We have a patient that comes every now and then. I've known him now for around 5 years. Quadriplegic patient, holds his neck in a very certain position, a very specific position, and then goes to a sort of straight line occasionally as well. When he goes to the left lateral position, the tube does tend to occlude, and he's formed a number of granulations up and down the tube, so that when you scope the patient through the tracheostomy, you can see absolutely no airway at all. It's like a ball valve, basically. We've got to the stage now where budesonide respials are not making any difference, and we've now got to the stage where we need to look at different tubes. So we've been looking at different lengths. So we've tried a shorter tube, which worked for a short period of time, then he formed another granulation, then a longer tube, so TracheTwist Plus to bypass the granulations, but again, the granulations just reformed in a different position, and it actually made things slightly worse. So essentially we're now at the stage where we're going to try the softer tube. There's the Tracho Comfort tube, which we may try, but I think we're probably going to end up with a Morse tube, which is really, really soft because of his movement. So it's just a really good example of how in the end the patient determines what tube selection you have to make. So we're going to try the Morse tube and see what happens with that, but maybe the Tracho Comfort will be the next one we try after that. So yeah, so just to wrap up, I won't keep everyone, I'm conscious it's quite late, but RWT, we had no NDT at all. There was no tracheostomy policy. There's no team, and thankfully over the last 8 years we've been able to form this amazing team around us. We hold clinics, we hold ward rounds, we hold meetings, we do presentations, and everyone's welcome to come and say hello to us. We have me as the ENT person. We have 2 great speech and language specialist therapists. We have our respiratory colleagues who come as well, and some nursing input as well, particularly from outreach. Patients come for routine tracheostomy changes, annual reviews, and there are new referrals that Emily tends to pick up on her trips out to the community. We do nasal endoscopy and endoscopic assessment of swallowings. of swallowing, and we do other administrative things during that. We've gone out to the community as well. We saw 6 patients in the nursing home, but we have yet to create a tracheostomy and laryngectomy team bus, but we're keen on doing that if we possibly can at some point. So that's it from me. Any questions? That's the generic email for us, but thanks everyone for listening to me.
Thank you, James. You have got some questions. So do you, do you have many young people coming through from paediatric services at 16 to 18 years old with long-term single lumen tubes? And when or how do you initiate move into a double lumen tube? What considerations do you discuss as a team before proceeding with that?
Yeah, it's a really difficult thing, isn't it? Where paediatric patients, we have really excellent connection with Birmingham Children's Hospital, and one of our team members is a paediatric ENT consultant, and we have currently 5 tracheostomy patients from BCH who basically we are very keen to deliver their direct care. So if they have problems, they come to RED rather than Birmingham Children's Hospital. The specific question that you ask about the tubes, I haven't got any experience of just yet because our patients are really small, sort of young. Yeah, I can't really answer that, I'm afraid, as yet. But yeah, you know, it's a challenge because these patients grow up and they become adults, and then suddenly you have to start asking these questions. What's next? How do we deliver their care, depending on what their pathology is or the reason for them having their tracheostomy? They're a really missed group of patients that, you know, I think miss out some of the decision making. Some of it's obvious for adult patients, some of it's really obvious for pediatric patients, but the young people are the difficult ones to transition into the adult world, and they get missed a bit, I think.
Thank you. Another one, what is the catchment area for your team?
Oh, that's a good question. Do you know what? We're not sure. At the moment, it's kind of expanding. The thing is, we're victims of our own success, really, because we invite everybody and anybody that wants to come. So we've seen patients from all over the UK who have either relocated or gone away to other places and then come back. The other complicating factor is we're on the Welsh border as well, so we do take patients from over the border sometimes. There are massive commissioning issues with that, and in the end I don't really care that much about the commissioning, but it's a difficult one because we're providing tubes and providing information and suggestions to patients that then go off into the ether of the community, and then there's the real difficulty about how they get their equipment via either primary care or PCTs, and it's just a bit of a nightmare, really. But the other thing is ventilation. So patients that are getting ventilator support from different areas, then that come to see us for their tracheostomies, and they don't necessarily get that connection between the two different teams, so that can be difficult to manage as well, going across borders. So yeah, it's difficult to manage. It really is an eye-opener working with community from secondary care.
I bet it is, yeah. Quick one from me as well. So you were mentioning about optimization in terms of things like saliva management. From the point of view of your team, do you have a sort of any protocol for what you use for saliva management, or a step up, step down? Because I know some places will sort of start with hyoscine, maybe then step to glyco, and then maybe look at salivary gland Botox. And there was some talk a while ago that I heard about where there was discussion about whether actually we should be looking at salivary gland Botox earlier in some patients.
I completely agree. The jury's out, really, and it's very specific to each patient. So some patients have already tried certain medication. Sometimes the hyoscine isn't enough and you just need to increase the patch. Sometimes it's too much and they're just too dry and can't manage their saliva and it's just not coming up. So it's very much dependent on the patient, and that's why it really is the true definition of an MDT. It's very exciting. I really enjoy our tracheostomy clinics because we're all challenging each other as to the ideas that everyone has, and thankfully we've got a massive room because we have about 10 people in there, all surrounding this poor patient who's at the mercy of all our decision making. But yeah, it's a really sort of inspiring environment.
Fab, thank you. If anyone else has got any questions, just bob them in the Q&A or the chat. But I'll just move this along. So whilst everybody is here, if anyone would mind just scanning the QR code and filling in a bit of feedback, I'll just pop the link in the chat as well if you can't scan the QR code. We'd obviously really appreciate that so we can continue to improve everything that we're doing. But otherwise, if there's no other questions, thank you so much to everyone for joining us, and thank you so much to James and Kate for joining us, because two really great views and different areas that you're working in, and lots of different thoughts for everybody to take into their clinical practice and hopefully help to apply to tube selection. Sam, have you got your hand up? No? Right, I think that is it. I can't see any more questions, so I will let everybody go and enjoy your evenings and have a good rest of the week, and thanks for joining us.
Thanks for organising. It's been great.
Lovely. Thank you so much, James.
All right. All the best, everyone.